Okay, thank you for this opportunity. So in this session, we are going to see three subsets which are traditionally surgeons' area. One is calcium, second is chronic total occlusion, the third one is left main. I'm starting with calcium here. So we all know this coronary atherosclerosis starts very early in the life, about 20 years of age, and slowly progresses. You can just see here, right? This is deposition of your cholesterol here, and slowly it forms necrosis. This all happens over years. And either it can produce whatever Dr. YVC discussed here. One is so you can create thrombotic lesions like this is a plaque rupture was traditionally you see, plaque erosion and calcium. So these things can happen, or these blocks slowly progress to chronic lesions. These chronic lesions either severe narrowing, total occlusions, or calcium. So this is the part, this may be the end of the road where it starts here and ends with the big calcium, total occlusion, or severe narrowing. So this is how your atherosclerosis, if you don't develop a clot and a heart attack, and ends with. So we are going to see this part here. So why this calcium is very important? So you just see that traditionally when you compare angioplasties which had calcium and no calcium, you see that calcium increases your patient-oriented outcomes by 12%, and target lesion failure by 21%, cardiac death by 44%, and revascularization, repeat procedure by 13%, comparing to when you don't have calcium. That is why this calcium is more important. Even though you have modern drug-eluting stents, still the outcomes remains inferior comparing to regular angioplasties. And why all these problems come? The challenges here, one, traditionally we relied on fluoroscopy to see your calcium. Calcium appears as a dark shadow during cardiac movement. So that is how you image calcium traditionally. That is not very accurate. About 50% of the time you miss calcium on fluoroscopy. The secondly, again, it creates a lot of problems. Your device delivery is the biggest problem when you deal with the calcified lesions. You can just see that how difficult to advance a balloon when you have a tight calcific lesion. And the third one, the devices, they don't perform well. You can just see that your balloon remain constrained in a calcified lesion. And in addition, if you put a stent in, it doesn't expand. You can just see that it is a stent which is expanded to the normal artery size. Here it remains constrained. When you leave this constrained stents, they are prone to come back with either a clot or with a repeat restenosis. Or when you're very aggressive, this is how you end up with. You can just see that the vessel ruptures when you're very aggressive. Or these patients come out with, when even you stent these patients like this, they come back like this with a narrowing within 6 months. So that's why this calcium is one of the biggest enemies of intervention cardiologists. So what we have in the modern era, now we have CT scans, which tells you whether you have big calcium or not. Even you take the patient into the cath lab. Now we have newer modalities inside the cath lab that shows you the distribution of calcium clearly, that is called stent boost. And we have modern intravascular imaging modalities. You can just see that. You can just put cameras inside your coronary arteries and just see what you see from outside. So exactly like a histology, you can see how much calcium is present. There are different parameters which are very important. One, how long is the calcium? Second is how thick is the calcium, and how much circumference is calcium occupies in your blood vessel. So all this information can be accurately assessed by putting these cameras inside. These facilities were not available earlier, but now we have these facilities and we know how to treat a different type of calcium. This you can just see that this is your calcium. This is an intravascular ultrasound. This is a sound-based imaging modality. And here you can just see that this is a calcium. This is your light-based imaging modality that is called optical coherence tomography. Exactly you know how much arc and what is the thickness and what is the length. Based on this thing, we can use a different type of treatment modalities for dealing with this calcium. So what are the various treatment options available when you have calcium which is thinner, that means less than 0.5 millimeter in thickness, you put a regular balloon, dilate, it shatters, you can just see that it fractures in many places and your stent expands very well. So this is the simplest of the treatment every day we do for regular angioplasties. Thins the calcium, it literally removes, it ablates calcium and make the areas thin, then that area is fracture, then your stents expands very well. This is called atherectomy. Either you just make the calcium thin by removing the part of the calcium, or you can shatter the calcium in many places. Next few slides, better you prepare the calcium, better you the stent expansion. As I already mentioned, the stent expansion is the one which is going to decide your outcomes. Okay, so now we are going through what are the different modalities available. First, I'm just going to show the modalities which fracture calcium into pieces. So this is a balloon. It is a high pressure balloon. It is called OPN balloon. The regular balloons just go up to create a 20 atmospheric pressure. These balloons create about 40 to 45 atmospheric pressure. This high pressure inside helps in fracturing your calcium. You can see here, this is a calcium. This balloon, put a balloon inside. And here this is an optical coherence tomography which shows how thick is the calcium. Here you can just see that balloon literally shatters this calcium and get the lumen bigger and put your stent and you get a beautiful stent expansion. So we are going to see some more cases in the later talks on this balloon. And the second one is called a scoring balloon, which has scoring elements. It is like wires that are on the surface here. You can just see that. That again apply focal pressure, more pressures in localized areas. That again helps in shattering your calcium. So this is the first one is a high pressure balloon. And this one is called scoring balloon because it has elements which can score the calcium. Okay, and we have a third type of balloon that is called cutting balloon, which literally it has 3 blades longitudinally mounted on the balloon. You can just see that. This is a calcium model, and this is your balloon with the blades mounted longitudinally on the balloon. Just slowly expand. You can just see that how it shatters the calcium. You can just see that how it cracks the calcium. And these are the balloons we have seen. A balloon which creates high pressure inside the blood vessel. The second one which has scoring elements. The third one which has cutting elements, like literally blades. And this a balloon, it is almost similar to what you see in urology. You shatter your renal stones. Similar things, similar technologies available for using in coronaries. You can just see that this is ultrasound emitters to create warped vapor bubbles, so that create pressures of 50 to 60 atmospheric pressures inside the coronary artery that shatters your calcium. So this technology is very much available. We use in our hospital regularly. You can just see that this ultrasonic pressure waves, the shock waves just again shatter your calcium. So the lumen compliance improves, and when you put a stent in, that expands well. And the technologies we are going to show for the next 2 minutes. So this is technology called rotational atherectomy. It literally removes. Just see that it is called atherectomy. You can just see that. This is a burr with a diamond chips on that. So you can just see that small protruding diamond particle that literally, and it rotates about 1,80,000 rotations per minute, RPM, 1,80,000. So just see that literally just remove the calcium to the size of the burr. It is available up to 2.5. We commonly use 1.25 millimeter to 1.5 to create a passage for your balloons to pass in. Then we put the balloons, then balloons expand well and stent expands well. So this technology is called rotational atherectomy. The next technology, what we are going to show is called orbital atherectomy. Similar one, it's just one single burr which orbits around the circumference and removes the calcium. You can just see that this is called orbital atherectomy. Again, this device is available in our place, so you can just see that when it goes back, you can just increase the orbit so that it removes so further calcium. You can just see that it is literally so this is an orbital atherectomy. So these two devices are commonly used, and particularly the first device when you are not able to cross with any of the balloons. And the next one is a laser. Mainly we use for lesions which are not crossed with any of the devices. We use this laser. Particularly we use it for calcium-related underexpanded stents, what we showed early. So all these new technologies made our calcium treatment feasible, and most of the calcified lesions we can address safely and without compromising patients' safety, and improve the outcomes. Once you put us to prepare these lesions with this type of technology, and patients get a good stent areas, and these things last longer, patients will have good outcome. I'll just show one of the cases done in our hospital here. This is a patient not suitable for surgery, and ideally has triple vessel disease. All three vessels had blockages. Ideally should have gone for bypass surgery because of his multiple other medical problems. It was not for surgery. This patient, you can just see that this is a rotational atherectomy I showed earlier. And rotational atherectomy, multiple balloon dilatation. This is the first blood vessel that is called the circumflex artery, and that was treated in the first setting. It was done in 3 settings. The second one, so here you can just see that this is again heavily calcified lesion with the 2 blocks here. It's not showing. You can see 2 blocks again, rotational atherectomy, multiple balloon dilatations followed by 2 stents. Sorry, this light pointer is not working. So this was done as a second stage after 5 days during initial hospitalization. The patient was sent home and brought back after a month. And this is the right coronary artery. You can just see the diffuse calcium. Even before you give contrast, you can see blood vessels. So that is actually calcium. And from origin to trifurcation, the entire artery was calcified. It was again treated, and multiple stents were implanted. So this patient totally had 7 stents implanted and had good results. Particularly when you achieve good lumens, good stent areas, these results are going to last longer. So these are the type of patients, olden days, if you're not suitable for surgery, managed only with medicines, could be safely treated with available all this new technology. So this patient, like bypass surgery, all the blood vessels have been addressed with your calcium modification strategy. Thank you.